really delighted that you're here. As Roger mentioned, I am an endocrinologist, but by the title of my talk tonight, you can see that my research interests are in the area, really in diseases that sort of at the interface of type 2 diabetes. So I do research in the area of cardiorenal disease and type 2 diabetes, inflammation in type 2 diabetes, and really excited to work with Roger Group and others in the area of type 2 diabetes and CNS disorders. So we just have 20 minutes or so. You can tell that I'm an endocrinologist and I stick out because my slides are a little bit different. Hopefully you can follow them along. This is the classic template that I use. Apologies if there's a different psychiatry-specific template. Here's my objectives. We'll spend the first amount of time to discuss the associations between cognitive dysfunction and type 2 diabetes. We've already heard a lot tonight, but let's just recap. Then we're going to move in and we're going to look at therapeutics that we have to treat type 2 diabetes. We'll look specifically at incretin-based diabetes therapy, a bit of a narrowed view. We'll first learn and understand the physiology of incretin hormones, and then move on to understanding the pharmacology of incretin-based diabetes therapies that Rodrigo just really eloquently described as well. Then we're going to, at the end, talk about the potential neuroprotective and pro-cognitive effects of GLP-1 receptor agonists. So without further ado then, let's just remind ourselves what's new in the landscape of type 2 diabetes in 2016. Well, I'm very fortunate. We have many therapies available to treat type 2 diabetes, good for us, good for our patients. However, despite all of this, you can see that our patients still die prematurely of macrovascular disease, stroke, and MI. We still have patients, thousands of patients every year develop microvascular morbidities. So you can see a picture of diabetic foot infections resulting in amputations. Diabetic retinopathy might surprise some of you to know that diabetic retinopathy still remains the leading cause of blindness worldwide among working age individuals. So we still don't have a handle of complications. At the bottom of the slide, you see the diabetic kidney, significant cause of morbidity and mortality. Now here, I think where endocrinologists are doing a better job, you folks have known about this for a long time, but we as endocrinologists are getting better at appreciating non-classical complications of type 2 diabetes, such as depression and dementia, in addition to others like increases in cancers and steatohepatitis. So I think that maybe we're gaining a better appreciation. I sit on the Canadian Diabetes Guidelines, and we have a chapter devoted to type 2 diabetes and CNS disease. So we're doing a better job, but you obviously were doing more than us to begin with. Let's look now about the association between type 2 diabetes and the risk for dementia. We'll first look at the associations in patients without diabetes. Here we have a graph. The yellow line is demonstrating the hazard ratio based on blood glucose levels. So you can see that if you had, this cohort was followed for 5 years and the average blood glucose level was linked to the risk of dementia. As you can see, by just increasing your average blood glucose level in patients without diabetes, there was a significant increase in the risk for incident dementia. What about patients with diabetes? Well, you can see there's a bit of a U-shaped curve. We don't understand all the nuances of why the folks who are actually in the slightly lower blood sugar ranges have a bit of a protection against dementia. But as you can see, when we get to blood sugars of 10 and 11 and higher, there's really a significant increased risk of dementia. And I think all of you probably already know this, but it's just nice to see the data. So what are the mechanisms that are linking diabetes with dementia or neurodegeneration? As we just focused on, certainly hyperglycemia seems to be a driving factor. But this, I really encourage all of you to read this reference, if there's one that you read from my presentation tonight. This is a really nice description in The Lancet describing type 2 diabetes, type 1 diabetes, and cognitive dysfunction. And here they really eloquently outline all the potential pathophysiological mechanisms that link diabetes with cognitive dysfunction. So we mentioned hyperglycemia, but also chronic and recurrent hypoglycemia, changes in CNS fuel metabolism. We can't forget vascular disease, so microvascular changes in the CNS, endothelial cell dysfunction, neuroinflammation, diabetic dyslipidemia, and also changes in the blood-brain barrier. I study kidney disease, where the main focus of attention is the glomerulus, this very protective and specialized epithelium. The same processes which lead to disease could be happening in the brain at the level of the blood-brain barrier. And again, looking at other endocrine factors, is it all just insulin? Probably not. There's probably other factors like leptin and other hormones that can be also influencing this as well. Of course, there could be innate CNS factors, genetics, the way an individual processes amyloid, etc., oxidative stress, as well as metabolic rate as well. So this is, really an interesting area. It's good news for young researchers like us because there's lots of work to do, right? Lots of questions to be answered. So what I want to do now is move on. We've linked cognitive dysfunction with type 2 diabetes over and over again tonight. Nobody knows the exact mechanism. Let's look at what we have available to treat type 2 diabetes in the present day. So depending on when you went to medical school, you may or may not think that we have lots of therapies available to treat diabetes. So if you're a person who went to medical school in the 1980s, maybe early 90s, back then, we really only had animal insulins and maybe sulfonylurea to treat type 2 diabetes. It might have been a really simple, disease for you to treat because you only had a couple options. 10 years later, you saw the introduction of many, many therapies. We had synthetic insulins, long-acting, rapid-acting, ultra-rapid-acting. We had glitinides, glitazones, inhaled insulin, pramlintide, lots of new agents. So that was just up to 2004. I graduated medical school in 2005, 10 years ago now. And even in the last 10 years, you can see that we really have had an explosion in the increase in number of therapies to treat type 2 diabetes. Now, these are the ones I am particularly interested in. Why? Because the former therapies that we have were really hindered with side effects. What are those side effects? Hypoglycemia and weight gain. What I'm particularly interested in these new agents is improved safety with the sense that these are smart agents like GLP-1 receptors, lowering blood sugar in a glucose-dependent manner. What does that translate into? That translates into safety in terms of guarding against hypoglycemia for our patients. So what you'll see here is there's many different classes, and there's a lot of complexity within the classes as well. We're just now going to focus in on a very narrow range, GLP-1 receptor agonists. That's not to say, as you just heard from Rodrigo, there's other therapies within the treatment of type 2 diabetes, like inhaled insulin, like pioglitazone, which may be neuroprotective and pro-cognitive. But from here on in, I'd like to focus on GLP-1 receptor agonists. My guess is if there's any of the current therapies available to treat type 2 diabetes that might have a pro-cognitive effect, it will be the GLP-1 receptor agonist in sort of the 5-year range. Before we understand incretin-based diabetes therapies and how we use these therapies to treat patients with diabetes, I always like to go back to first principles and understanding what is an incretin hormone. This was an observation made over 60 years ago now. We have in the upper graph a pink bar and a yellow bar. These are just groups of patients. They've done it crossover, they've done it separate. Essentially, if you treat a patient with glucose, you give it to them orally as demonstrated in the yellow bar, and you gave them a proportional amount IV. You can see that the amount of insulin that is secreted in response to a proportional amount of glucose is much greater if you give it to the patient orally. Why is that? That's because the gut, it all comes back to the gut. The gut's a smart organ. It not only absorbs nutrients, but it sends out signals to the peripheral organs, such as the pancreas, saying, hey, we've got carbohydrates coming in. We need to have insulin around to dispose these important nutrients. So it's these hormones that are called incretin hormones. The first one discovered, GIP. The next was GLP-1, and it turned out the one that's most relevant in humans is GLP-1. The reason why we use it in patients with type 2 diabetes is evident in this next graph. There's a blunted incretin effect in patients with type 2 diabetes. So what that means then, using incretin-based diabetes therapies, we're replacing endogenous incretin axis, or we're activating it pharmacologically, which I'll show you in a moment. So I'll skip this. What does GLP-1 stand for? GLP-1 is glucagon-like peptide 1. Here's the gene. Interestingly enough, it's on the same gene as glucagon. All of you went to medical school, you recognize glucagon, important counter-regulatory hormone, raises glucose. How come we have on the same gene GLP-1? Why is it called glucagon-like when GLP-1 actually lowers blood sugar? We don't know, but we know that at some point this was considered, this is highly conserved among different animals. It might be a protective mechanism against profound hyperglycemia, but it turns out that GLP-1 lowers blood sugar. It's not named glucagon-like because it does any glucagon actions. In fact, it inhibits glucagon, but it's named so just because of sequence identity, and no one really knew what the peptide was doing. When proglucagon is expressed in the pancreas, the major product is glucagon. Now, when you take this same gene and you express it in the intestine or the brain, important to remember this is also a gut and brain hormone, the major products is GLP-1 and GLP-2. And I was sort of laughing a bit to myself earlier because I was kind of wondering, why am I the last speaker? And I was thinking, well, you know, GLP-1 relates to everything. GLP-1's levels are increased after bariatric surgery. GLP-1 and GLP-2 really have a significant role in the gut microbiome. And then with Rodrigo, we heard about GLP-1 receptor agonists. So I think probably that's why it is. So GLP-1, gut-brain hormone, and we use it to treat type 2 diabetes because of the blunted incretin effect. So we heard about GLP-1 receptor agonists. Rodrigo introduced you to liraglutide. There's not only just one GLP-1 receptor agonist, there's a whole group. And you're going to see your patients with type 2 diabetes on these therapies. They're available in Canada, and they're not all created equal. What they differ by is by sequence and structure. So half of them are actually based on Exendin-4. What's Exendin-4? It's a lizard. Yes, you heard that correctly. A lizard GLP-1. Turns out that this lizard GLP-1 binds with tighter affinity to the human GLP-1 receptor than human GLP-1. So that's why we use it. And then the remainder is actually based on human GLP-1. So they also differ by structure. They are modified so that they last longer in the bloodstream. And these modifications are relevant to our discussion tonight because of size. So as you can see, some of them are tandemly linked GLP-1s that are then linked to albumin, and some of them are also linked to an FC IgG molecule, which makes it large. Why is that important to you? It's important to you because some of these larger analogs that can be administered once weekly may not equally cross the blood-brain barrier. So some of the, for instance, neuroprotective effects we see with the smaller molecules may not be translated to some of the larger molecules. Lots of research still needs to be done. Good news is we have both once daily and now available in Canada, 3 different agents that are delivered once weekly. So really wonderful for patients with diabetes, treating their diabetes with 1 injection per week. One quick point, you're going to see a lot of your patients on DPP-4 inhibitors, and I do not want you to make the mistake that many, I would say many physicians make in that assuming that DPP-4 inhibitors are kind of the oral equivalent of GLP-1 receptor agonists. They're not. They're different. They are considered incretin-based therapies because they still work through GLP-1, but here's how they differ. DPP-4 inhibitors are small molecule inhibitors of DPP-4. What's DPP-4? It's an enzyme that breaks down your natural incretins. So what DPP-4 inhibitors do, if you think of that little guy as Pac-Man and the little diamond as a DPP-4 inhibitors, it stops Pac-Man. Pac-Man cannot degrade GLP-1 and GIP, and so you end up boosting your own levels of endogenous incretin hormones. What does that mean? Well, that means we all have different levels, inherent levels of GLP-1, and so you just boost what you already have by 1 to 2-fold. Still efficacious, not quite as efficacious on glycemic endpoints as GLP-1 receptor agonists, but widely used for treating diabetes. It's in fact the number 2 prescribed medication for the treatment of type 2 diabetes after metformin. But it is different than GLP-1 receptor agonists. This is working on endogenous GLP-1, where, of course, GLP-1 receptor agonists are giving suprapharmacological levels of GLP-1 receptor agonism. So important again, DPP-4 inhibitors do not cause weight loss. Some people believe it's because you just don't get enough endogenous GLP-1 to stimulate weight loss, whereas GLP-1 receptor agonists, because they are directly hitting the GLP-1 receptor in the CNS, you get weight loss. So differences, not all created equal. Why I'm here tonight is because GLP-1 doesn't just work on glycemic endpoints. There are GLP-1 receptors throughout the body, and we'll talk now about the pleiotropic effects of GLP-1. So again, today we've just sort of focused on GLP-1 receptor agonists and its glycemic effects, but GLP-1 receptor agonists do more because there is expression of the GLP-1 receptor throughout the periphery. So some key organs where the GLP-1 receptor is expressed is in the heart, and we can see that GLP-1 receptor agonists increase LV function, so that's a cardioprotective effect. In the gut, they inhibit lipoprotein metabolism, so that's good effects on lowering cholesterol. In the kidneys, they promote natriuresis, and this lowers blood pressure. And we for sure know that within the CNS, it promotes satiety and is associated with weight loss. Now what we're going to ask ourselves is, does it do more in the CNS than just lower body weight? And right now, in terms of our understanding of where the GLP-1 receptor is located in the CNS, we've really just relied on mouse brains. As we know, mice and men are not the same, and so this is a very nice demonstration in the literature. These investigators use 3 lines of technique in order to localize the GLP-1 receptor. It's a very challenging receptor to localize, and it really is a great reference tool because it really did a great job in localizing the GLP-1 receptor. What did they find? They found, as you can see, just you don't even have to focus in on any particular area, the GLP-1 receptor is widely expressed throughout the brain. So even though endogenous GLP-1 is just made in the brainstem in a really specific nucleus, the nucleus of solitary tract, the receptor is expressed all throughout the brain. And I think what that leads us to is that there could be many roles for GLP-1 in the brain and many effects of GLP-1 receptors throughout the CNS. Did they find any differences between primates and rodents? Yes, they did. As you can see, the amygdala expression of the GLP-1 receptor was much higher in primates than it was in rodents. And what you can see missing here as well, there was no or very little protein expression of the GLP-1 receptor in the hippocampus. And we'll see why that becomes relevant next. The major area of GLP-1 receptor, as we would guess from its satiety effects in the hypothalamus, are in the arcuate nucleus. So as Rodrigo touched on earlier, there's really a wealth of preclinical data, both cell models and just a variety of murine models, which really have provided just real strong evidence in the preclinical literature that GLP-1 receptor agonists go beyond glycemic effects and have neuroprotective effects in the brain. So here we have them listed: increasing neurite outgrowth, increasing differentiation, promoting synaptic plasticity, particularly within the hippocampus, affecting associative and behavioral learning, protecting against degeneration, and reducing neuroinflammation. When you take mouse models and you administer GLP-1 receptor agonists, overall there's a reduction in tau pathology and a reduction in beta amyloid plaques. I don't have time to show you all of the data. Here's a really nice study that was one of the first in the literature back in 2011. This is in a mouse model that has accelerated Alzheimer's dementia due to increased beta amyloid. When they took 7-month-old mice, treated them for 8 weeks with liraglutide. So this is peripheral, not intrahippocampal, just peripheral administration of this medicine. We got a reduction in beta amyloid plaques, a reduction in inflammatory response as judged by microglial activation, and also, as you can see in the dentate gyrus, this was associated with neurogenesis, or stimulating young neurons to grow in the dentate gyrus. It's nice to see all of these genetic models of Alzheimer's dementia. What about just age-related cognitive decline? This is probably, I think, the most important demonstration in the literature in 2015. This is in a mouse model of age-related senescence, so sporadic Alzheimer's dementia. Again, what they did is they treated old mice, so 10-month-old mice that had cognitive effects. They treated them with liraglutide, as you can see in the yellow bars. They used a T-maze avoidance test. I don't know all of the intricacies. I'm sure some of you would. But as you can see, the animals that were treated for 4 months with liraglutide had better performance in active avoidance. And so this was related to increased spatial learning. Again, this was associated with increasing or preserving hippocampal neuron models. So this wasn't beta amyloid or tau, but this was preserving hippocampal neurons. So I think really exciting data in terms of preclinical models. Do we have any data, say for what Rodrigo just showed us with respect to neuroprotection and GLP-1 receptor agonists? We don't. There was 3 rather nice studies with GLP-1 receptor agonists and CNS endpoints in the last year. What they have to do with is in patients with type 2 diabetes and demonstrating that peripheral GLP-1 receptor administration can affect the CNS. We still don't fully understand how these agents and which ones cross the blood-brain barrier and what are the central effects with respect to the obesity and also neuroprotection. In this study, patients with type 2 diabetes and obesity showing different food cues. So some look like really yummy food, high calorie. Other ones were not so great, low calorie. And what you can see was that the effect with functional MRI imaging was liraglutide was able to decrease CNS activation in key areas that regulate feeding. So having said that, we have a wealth of preclinical data. We still only have small studies in humans, and that is pretty much limited to understanding the role in feeding and reward circuits. We don't have any robust literature suggesting that GLP-1 receptor agonists are neuroprotective in humans, so don't go out and prescribe this to all your patients because you heard Julie Lovshin say that it was neuroprotective. It's indicated for the treatment of type 2 diabetes. Might surprise you to know that there are several ongoing studies, so there's enough preclinical literature to support large studies in Parkinson's and Alzheimer's disease. None have reported yet. We're looking in the next couple of years. The only one that has been reported was in 20 patients in a pilot study in Parkinson's disease, and this demonstrated a potential neuroprotective effect. Patients who were treated with exenatide improved motor scores, and this was found to be preserved even 2 years after washout. So excited, and that fueled a larger trial. I'm going to end there. What have we learned just in this whirlwind tour in 20 minutes? We just reiterated that that cognitive dysfunction really is an important and emergingly understood complication of type 2 diabetes, and there's many pathways that get us there. GLP-1 receptor agonists, not all created equally. They differ by structure, and they differ by size. The GLP-1 receptors itself is expressed in many sites in the CNS, so there really is biological plausibility that GLP-1 receptor agonists may have many roles in the CNS. Finally, you heard about some preclinical literature, very strong evidence for GLP-1 receptor agonists and neuroprotection. Do we have the answer in humans? No, but in a few years we will see whether or not these really nice preclinical studies translate into solid outcomes in ongoing clinical trials. I'm going to end there. I have to thank my long-term mentor and supervisor, Dan Drucker, and David Cherney, whom I work with. And I want to give a big thanks to Roger and his group for inviting us here tonight. And I really think it's been a spectacular symposium. So thanks so much.